All right, I'll show the first case, which is a nice finding that one of my residents made. So let me first show you the CT that is the more recent one that he saw. And let me make sure I've got the right sequence. So it's right here. So here is the esophagus. I'm just going to get my scroll function fixed. Okay, containing some air. Then you'll see the esophagus here, fine. Here we see calcifications in a small lymph node or lymph nodes. And then just here, just at this level, there is an air-containing structure that contains some air, as well as perhaps something else right there. So that's a really good observation that he made. And now alongside that, I'll bring a comparison exam. And this one should suffice. Let me unsync that. And here you can see, I'll make this bigger, a really nice example of a small traction diverticulum. So here is the diverticulum. Here's its communication with the esophagus. There's the adjacent calcified node. So clearly some food has accumulated within this small traction diverticulum. So that's certainly a classic thing, traction diverticulum versus pulsion diverticulum. This isn't very big, but I think we can confidently make the diagnosis of a traction diverticulum, small. Okay. This is a patient that has metastatic large bowel cancer, and here is one metastasis, a relatively large metastasis in the central portion of the right lower lobe. It was decided to remove that. So we had the surgery, and here is the immediate post-op with right pleural space drainage tubes in place. And here is a following one. So here we have 2 days between these two. And you can see that a substantial amount of opacity has developed in that right hemithorax. There is abnormal opacity there, but certainly here quite substantial. It's hard to know or easily know how much of this may be pleural space abnormality, how much of it may be pulmonary abnormality. But certainly this CT, which was done the next day, shows that it is a pulmonary abnormality. And that's what it looks like on the axial CT, and I'll bring over the sagittal, and you'll see the same findings. Now, what I want to do here is show you the location of the staples in the right lower lobe where the lesion was, and I'll make this a bit bigger. So, for example, here we can see where the opacified pulmonary artery is, beyond which we don't have opacified vessels, and the relationship between these staples and it there. And if we go look for any blood flow through the lung to the pulmonary veins, we see staples, but we don't see any blood flow going through there. So this is very consistent with ischemic injury to the lung, undoubtedly pulmonary hemorrhage. How much actual infarction is present is at the time unknown. So actually he wasn't very sick, and in fact he went home with the abnormality and was followed up at the clinic over a period of time. And let me show you the last CT we have, which was just the other day. So now we have March compared to December. And here we can see that indeed he's got findings of pulmonary infarction. There are some areas of cavitation that have developed within, like here and here. still persistent abnormality in the lung consistent with that ischemic injury. So I personally think that they stapled off some vessels, resulting in that complication. But he's out and about.
So Howard, where's that gas medially?
Here.
Yeah.
I think it's in the area of injured lung.
Okay.
That one. Within the anterior medial portion of the ischemic infarcted lung. Now, there's some residual aerated lung here, quite abnormal, but I think the solid areas and the areas where the cavitation is are obviously areas of infarction, I believe, actual dead tissue. Any comments otherwise? Do you think I have it correct?
I agree.
Yeah.
That's venous. You said venous infarct, right?
Well, I think, in relation to that pulmonary artery, let me go back to the coronal. I think it's likely, let me go back to say this.
I wasn't looking at the imaging. I just kind of had that venous infarctable lobe appearance, but did they knock out the PA?
Yeah, I think they did. I think that some of the staples right here did get pulmonary artery as well, I think.
Yeah.
In this region right here. You can see the vertical rows of staples going right to that point, right across here.
What was the surgery for?
To remove a metastasis via
it was just meant to be a wedge, and they somehow knocked out the.
Well, they took a generous amount of lung tissue out, but you can see that it's a pretty central metastasis.
They should have just, well, he got his lobectomy, I guess, one way or the other.
Functionally, yeah. But it's amazing that apparently he's doing okay.
I would think that would be very painful. Maybe that's surprising.
Yeah. Let me show you this one. Okay. So this is a patient that has a very large adrenal gland mass on the left side. And you can see its attenuation characteristics and its perfusion, maybe some calcium. Yep, definitely calcium in portions of it. Interestingly, that turned out to be, initially after they removed this and evaluated it, they weren't really sure what tumor it was initially, but eventually the pathologists settled on a large ganglioneuroma for this lesion. So that was removed, and the op notes described an uneventful procedure for removal of it. And here is chest radiography on post-op day 1, and you can see the patient is not intubated, not in the ICU with tubes or anything, and here is the frontal and lateral. So we have abdominal air, not surprisingly, but of course up here we have abnormal air. There is a fluid level. There is some fluid and air in the pleural space up here as well. So very concerning for what you'll see on the subsequently performed CT. So here we have the coronal and sag, and you can see where and how large the diaphragm defect is right down here. And going to that same area, you can see where the stomach has come up through a large diaphragm defect. So the stomach is very distended. There is not torsion, but there is kind of an angulation here. And at surgery to fix this, they identified some ischemia related to the stomach and had to remove a portion of it as well in the corrective surgery.
Where was the initial tumor? I'm sorry. Was it abdominal or was it
adrenal gland?
It was a left adrenal. Okay. And you said it was a ganglioneuroma?
Yeah, apparently it was a ganglioneuroma.
It's fascinating. I should have left adrenal ganglioneuroma last week.
Oh.
And I'd never seen one before. That's pretty random.
Oh, yeah. So let me see. I think they also saw some findings here of maybe an injury to the spleen as well. So it wasn't uneventful surgery as it turned out, or at least turned out not to be that. But they were able to repair the diaphragm. They said it was lax enough that they could do a primary suture of it. And they removed a portion of the stomach, which was described as ischemic. And I think they did a splenectomy as well. So iatrogenic left hemidiaphragm injury with gastrothorax. Okay, I'll stop there for the time being, Jeff. I can show more if you want later.
All right, thanks. That's an impressive one.
Yeah.
All right. Did anyone else not get to go last week? All right. Well, whoever wants to go next can.
I have some cases if you want.
Of course.
All right. So, where should we start today? That one's a little, I'll start with this one because this is just weird. Unfortunately, they didn't get an abdominal study because I'm not even sure why the patient came in. She's kind of on hospice and was deteriorating rapidly, and they brought her in. But I had never seen this before. So this patient has clearly awful metastatic lung cancer. She's probably got a superimposed pneumonia. But the point being is that you see there's this large necrotic mass in the left lower lobe. You can see the bronchus going into that mass. And then you can see that mass continuing through the diaphragm, going into this large structure in the left upper quadrant. And initially I thought it was going to be going into the stomach. But she had outside, so I called the ER because of course this is a PE study and the only history I literally get is just shortness of breath, like I think we all get. And I say, there's this big fistulous thing between her necrotic lung cancer that is eating through her diaphragm and into her stomach. And they're like, no, it's the spleen. She has an outside CT and we know that she has a lung cancer that is eating into her spleen. So this is a bronchosplenic fistula, basically. And I don't know how she's not hemorrhaging everywhere, but I guess this has been known for some time. I mean, I've seen lung cancers eat into a lot of things. I've just never seen it go into the spleen before. So I thought that was really weird.
Wow.
This case, what case is this? Oh, this is just an interesting case because it's just an association I didn't know about. And I might as well pull over, I think, the contrast enhanced one. Might as well. Or is this even contrast enhanced? This one is. So this is a patient with, you can see all these skin tags on the, or no, they're not skin tags, they're neurofibromas on the skin. No clear lesions elsewhere, but she has raging pulmonary hypertension, those nice kind of what I call perivascular blushing, some small cysts, which, not really specific. There's a couple of them. Those can be seen with neurofibromatosis. So theoretically, but it is a rare cause of, there is a known association between NF1 and pulmonary arterial hypertension. That's been reported to occur in a higher percentage of individuals than the general population by a significant margin, although it's still, relatively not super common. So we see a lot of obviously pulmonary hypertension and CTEPH here. I just never seen a case in someone with NF. So it's just a random association I learned about the other day. This is, if I can get this thing to load appropriately. Let's see if this will load appropriately or not. Maybe it won't. So because this is a cardiac MR, obviously, and this was the perfusion scan, and you can see that on the perfusion scan, she had a device in. You can see there's a pacemaker here. There is this large ball of basically absent perfusion extending through the myocardium, and initially I was just trying to wrap one of my younger faculty showed me this, and I was just trying to wrap my head around what it could be. Was it related to an infarct? The patient supposedly had a history of a coronary embolism that led to significant abnormality, and that area is, kind of down, especially as you get towards the mitral annulus, it's not moving. But the myocardium around it actually doesn't look that horrible. It's a little down, but not dramatic. And it took me a while too longer than it should have, to figure out what the heck this was. And then once I just kind of sat back and said it's so low signal, and I was like, scrolling through, and then it was here, and I'm like, oh, it's got to be just raging caseous MAC. And we've seen cases of caseous MAC that, as I said, oh, and then I said, oh, why don't we look at the plain film, because we actually had a plain film to clear her for MR, and you can see that. I'll show the lateral. So there's really pronounced caseous, or at least there's mitral annular calcification, but there's this big ball here, which is presumably that caseous portion, which corresponds exactly to where we expected that lesion to occur in that inferior lateral segment at the base. So I told them they can get to, I told our junior faculty that they could tell them to get a gated CT, because it'd be a nice correlation, but presumably that big area. And we've seen cases, people have shown cases here where it extends into the myocardium. Once or twice a year, people show a nice case of that. So this was just a nice example of caseous MAC that on MR threw me for a loop for about 10 minutes until I recognized it on the scouts and kind of just thinking about it.
Hey Seth, do you have any delayed post-GAD images on that one?
I do, and it doesn't enhance.
Like not even the edges of it?
The edges may enhance. Let me see. Yeah, there's some enhancement around the edges of it.
Huh. And any T1 or T2 imaging?
We got tissue mapping through it, but I didn't include those. Why? What were you thinking?
I agree. It can throw you for a loop when you see it on MR, and the CT is so much better. But I've seen a few cases like this where the edges of it are enhancing, and then it's variable T1 and T2 signal, but usually the caseous part is typically T2 or stirb, right?
Yeah, we didn't get any T2 through it. We have a tissue mapping, and on the T1 it's pretty low signal throughout. But I have to. I didn't pull those over, because once I kind of recognized it anatomically, I just I didn't go much further into it. This is an interesting case because it just I'll show it. Shows multiple pathology. So this is a patient who, and we've shown many of these cases before, that had these numerous little nodules, and you can see some of them. If I will find one, they're all over the place. We'll have that little Cheerio sign, but she also had this nodule, ground glass, mixed solid ground glass, subsolid, whatever you want to call it. That's mostly subsolid. I guess there's really not a solid component, but that was taken out, and over time, let's see here. So we've been following her for years, and the ground glass nodules are really, most of them are really unchanged. Here's a nice one with the Cheerio. But some of these other nodules are kind of growing a little bit. And you know, this one is probably, there's one down here somewhere that's probably on the adenocarcinoma spectrum. But the issue with this was more the pathology. So the pathology came out in the from the right upper lobectomy. And you know, the question is, what do you do with all these ground glass nodules? Because some of them were a little more dense. This one was increasing in size over many years. So this is, that's not, oh, here it is. This is her pathology. And if you look at the pathology, you can see that there was, I thought it was just putting my arrow on. There was the adenocarcinoma. There were the multiple pulmonary meningothelial-like nodules, or those Cheerios. There were also carcinoid tumorlets, and there were also multiple areas, does it say it here? Multiple areas of AH. So this was just, you know, we often see AH associated with multifocal adenocarcinoma, but this patient also had the meningothelial-like nodules and multiple carcinoids, tumorlets kind of superimposed on it. So it was not a fun case to follow up because I was trying to sit there, and then eventually I just trying to determine what was what, but eventually just gave up and said it's not really changed over many years, and just keep following those subsolid nodules that appear a little bigger. I just had not seen a case where we had 4 pathologies that all could look like cancer, or, oh, and she also had lymphoma, axillary lymphoma. So anyways, I just had that case like 10 minutes ago. I thought that was interesting.
That's awful.
Nice you have the path
yeah.
meningothelial-like nodules.
What?
Nice that they had the.
Do you have any
meningothelial nodules?
I'm sorry. Do I have path?
No. It's nice that there was a biopsy that showed, or this lobectomy specimen that showed those nodules.
Yeah, because I was looking, I'm like, man, these, you know, first I was thinking, oh, it's just going to be multifocal adenocarcinoma,
Right.
but I'm like, no, these are too small. They're little Cheerios. And then I went back to the study in 2013, and they're basically essentially all there.
Right.
Although the shift in the lung drives me crazy trying to figure it out. And I'm like, oh, these are, but then I'm like, oh, but there's this solid nodule up here, and that kind of sprouted up. And there were some other ones that are a little more solid. That's the mucus plugging.
Mm-hmm.
And then I went back and I was like, oh, she had carcinoid tumorlets, but she doesn't have, anyways. And then, yeah.
Does she have any air trapping on an expiratory or like a PET?
No, well, we don't have expiratory, but she's not mosaic, and she doesn't look like a dipneic patient. And carcinoid tumorlets are not, they're very, very common, as are the meningothelial-like nodules. They're very common as well. So.
Under the microscope, yep, as incidental findings, yep.
I'm sorry?
Yeah, exactly, as incidental findings, yeah, under the microscope,
yeah.
Yep.
But they did comment on in their little spectrum about how there were an abundant amount of the meningoendothelial-like nodules. So anyways, those are my cases.
Awesome. Okay, who wants to go next? Travis, David, Brian?
A couple.
All right.
If I can show some whenever.
All right, as soon as David goes, you can go next. How's that sound?
So this woman had this set of radiographs back in 2011 showing pulmonary hypertension. She had CTEP. She got thromboendarterectomy. And a while later, this is current now imaging, things have not gone well. Her pulmonary arteries are more enlarged. She has calcification in the walls of the artery, reflecting the atherosclerosis from long time pulmonary hypertension. And CT was also abnormal, as you might expect. Massive pulmonary artery enlargement, lots of thrombus in these pulmonary arteries. It's hard to know in this setting whether this is recurrent embolic stuff or whether it's just in situ thrombosis, given how big these arteries are and how sluggish the flow is. She also has left heart disease, and she actually presented with myocardial infarction at this point, or actually she had presented with myocardial infarction before this study. And the reason that she has myocardial infarction is that her pulmonary artery is so large that it's squishing the left coronary artery. And so here's the left coronary artery being very compressed by this. So this artery got a stent and you can see the stent in place here because the pulmonary artery was squishing it. So this was ischemic heart disease. She now has an ischemic cardiomyopathy because of this massive pulmonary artery enlargement. We think we can see it on lateral view too, where it is sitting on top of the left coronary artery here. Here's the stent. So Seth, have you seen any pulmonary artery encroaching on coronary arteries like this?
Yeah, I showed a case about 4 years ago that was the exact same issue.
Yeah,
Massive PH that included
remember that. So yeah, okay.
And then what's interesting is I really wonder if she actually had CTEPH. Because I'm telling you, man, I have to write something up because it is really hard. I mean, we all think intimal thrombus and in situ thrombus like this case where you have that layering calcification, but in some areas it creeps into the distal vessels and it occludes them, and the surgeons get really, you know, I've called some of them, you know, mixed, and then they come back to me like, dude, this is all in situ thrombus, this is not CTEPH. And I'm like, I don't know how you tell in a lot of cases. You know, is it mixed disease? Is it one versus the other? I don't know. It's hard. Can you show some of the distal vessels? Are they open or are they occluded as well from this? I mean, that's really impressive mural thrombus. Yeah, so that's wow.
They're gone.
Yeah.
They're gone on the right.
Early. It's a little early phase, but yeah, they look gone. I wonder if they, and the reason is that they say here that, you know, the endarterectomy doesn't really work on the in situ thrombus, that it just reclots it. All right, I got to take this. Thank you.
Okay. And then let me show you this lung transplant person who felt the sensation that there was rattling coming from her right lung. So her lungs are nice and clear. Lateral view looks just fine. And I can't really see what the problem is, but that's why God invented CT. So let me show you what her CT scan shows. And there is this very bright object sitting in a right lower lobe bronchus. So this thing is roundish, and let me show you on coronal. It seems to be roughly spherical, and it's very dense. And I think this was fairly recent after these sensations began. So this isn't as if this is a chronic lesion that has calcified over time. So this is very bright. And this was attributed to one of her tablets. So she takes calcium citrate, and she also takes a magnesium tablet. So it's thought that one of these tablets here got aspirated, and we have this very bright object. She had been on iron, but iron was actually discontinued. That was in the past. And if this were really iron, it would be even denser than this. And the iron component would be in the center rather than on the edge. So I think that this is probably her calcium or maybe a magnesium tablet that got lodged here. And surprisingly, there's not much in the way of atelectasis. Once they removed this thing, there was a lot of pus that came out. So there was some stuff accumulating, but it hasn't caused a lot of atelectasis. And here is some bronchoscopic pictures showing you this very bright grayish thing. They noticed some discoloration in the wall of the bronchus after they chipped this thing out. They had to hack it apart and then to get it out, so it was not removed intact. And there was no pathologic analysis of it. They did submit it for bacterial cultures because of the low-grade infection she probably had distal to it. So they noticed some discoloration on the wall afterwards. So probably an aspirated tablet that got stuck in this bronchus. Okay, those are my two quick cases. I wanted to leave lots of time for Travis.
Awesome.
Hey Dave, we don't see any or many lung transplants here. Can you comment on what you think of her symptoms? You said that she only felt some rattling, right? Like, so they've altered sensorium. I'm imagining after transplant.
Well, I think she probably had stuff gurgling around this thing, and that as you breathe in and out, there's probably some gurgling of secretions trapped behind this thing, and that's what she called a rattling sensation. So I don't know what their sensations are, but she felt this. Okay, guys.
All
thank
right,
you.
thanks, David.
Thank you, David.
All right, you see my database screen here? Okay, this is a quick one and just a fun radiograph. I was pulling this case up for a talk and happened to notice a finding that hadn't really been appreciated first. But I think a couple things. Number one, there's a nice circumscribed mass here, nice hilum overlay sign, and this also has like a complete border sign, so you can see that it's probably in the lung parenchyma. And if you look at the lateral view, you can see that it is in fact in the lung parenchyma. Why I liked this though is I was actually looking for a case of an incomplete border sign, and here you can see a second lesion, and this is easy to overlook because of satisfaction of search. And so on the same side in the same patient, you have somebody that has something with a complete border and you have one with an incomplete border. So of course this suggests it's either abutting the pleura or rising from the pleura or chest wall, and there's no destruction of the underlying bone. And so this one's just a little lipoma in the chest wall. And sometimes these get called pleural lipomas, or extrapleural, but this one probably just arose outside of the intercostals, because you can see there's some breach of the intercostal there. And then this did turn out to be a hamartoma, but just, I don't know, a nice radiograph with some fun teaching points to it.
Yeah. Great.
Two for in the same lung. Now this is something that my pathologist just brought to our attention yesterday, which I had never seen or really heard of before. And all I have is the biopsy CT, unfortunately, but this is so I'm not sure how this got to be biopsied at the outside, but lady has this subsolid nodule in the right lower lobe that's just over 1 centimeter. And Kirk often gets these outside consults on pathology cases. So he had this biopsy CT available for us. And you can see, I think they did an FNA first, but then they also did a core, and you'll see they definitely got it. They're deploying this through the lesion here. And then the histopathology on this came back as a solitary pulmonary capillary hemangioma, which I was not familiar with. It's essentially like a true hemangioma, not like the pneumocytoma, which used to be the now I'm blanking on the name of what that was. The other one that had hemangioma in the name.
Oh, yeah,
but
they call it a sclerosing hemangioma.
Yeah, right. Yeah, the pneumocytoma. So this is actually just dilated vascular channels along the alveolar septa. And he actually put a lot of references in here. So I pulled up one of those. And yeah, so the solitary pulmonary capillary hemangioma. So it just presents as a GGO, and this one looks very similar. And you can see that they do some stains, and there's stains for capillary endothelium along the alveolar septa. Have you guys ever seen one of these?
No.
Nope.
I mean, not that we need more things for a GGO differential, because again, this is still 99 times out of 100 going to be some sort of adenocarcinoma spectrum. So, but Seth, I was wondering maybe if you had seen one of these at the AFIP.
Yeah, we had one in Maryland about 10 years ago or 9 years ago with
Okay.
nice path, but yeah, we get maybe 1 or 2 of these a year sent in. Maybe at most, maybe that's an exaggeration, maybe 1 or 2 every, couple of years.
So yeah, nothing remarkable about the imaging appearance, just something else to throw in the differential for the rare instances.
Yeah. Mm.
Now this one, on the other hand, is quite dramatic. This is a patient who had a type B dissection. They had an endovascular stent graft placed several years ago. They had a carotid to subclavian artery bypass, and you can see a plug occluding the left subclavian. And we'll start with the radiograph here. Let's see, that was 2016. Actually, I can get rid of that. This is 2021. And anybody want to comment on the new finding they see on the radiograph? This guy's had worsening back pain for 6 months and some B symptoms.
There may be an opacity in the lateral to the stent on the left side, medial basal left hemithorax, maybe?
It's actually, I'll zoom in and you can
How about the
see.
lucid? We've got gas in the mediastinum.
Oh,
Yeah,
oh, now I see
yeah.
it.
There's gas around the graft, and you can see here. And this was the follow-up radiograph, and so in between, did a couple of CTs. But you can see this thing is chronically. It was chronically thrombosed. There was never filling of this false lumen, which is kind of interesting on its own. But they had gotten a good proximal seal. But there's just gas throughout the excluded portion of his dissection. And I've got a CTA, and even on the venous phase, you can see there's no filling. Obviously, there's no communication either way. Gas wasn't getting into anything else, and contrast wasn't getting into that. There are no other symptoms other than back pain and just symptoms of chronic infection. So he's been on IV antibiotics and just got discharged home on lifetime oral antibiotics for presumed chronic infection. So pretty dramatic appearance, but a nice pickup on the radiograph.
Yeah.
Was the workup of his esophagus to see if there was a fistula from his esophagus? Because
Yeah, there was, and no esophageal symptoms, and because there's a reasonable fat plane in most areas, I think, like especially up. It doesn't look like the esophagus is tethered there, and sometimes, as we've seen with aortobronchial fistula, there's the lung around here looks pretty pristine too. So
they're calling this a gas forming organism then? I'll bet you there's a fistula to some gas tube.
Yeah, I got to be coming from somewhere. It's not just vacuum phenomena. I don't know, but he's not really a surgical candidate. He has other comorbidities, strokes and whatnot, but has never had any GI bleeding, no hemoptysis, no other symptoms. So I was just showing it.
Dave, that's
mostly for
interesting
the
you say
findings
that,
on the radiograph.
Were there
I
any
had a
Travis?
similar case, and Pugach a long time ago said, because I couldn't see a fistula, and he said, you're not going to get a gas forming organism. It's got to be a fistula, and he was eventually right. But the question is, why couldn't it be a gas forming organism?
Because the gas is so sparse, and if this were a gas forming organism, it would be spread all over the place. It wouldn't be just hugging a few contours like this. Did they sample the fluid by any chance to get an organism out of this if they're lobbying for infection?
I don't think so. I think they were trying to be as hands off as possible just because of his comorbidities.
Right.
Yeah, but I agree with you. I'm wary that there is some sort of fistula that may declare itself at some point.
Yeah. Got it. Thank you.
Yeah.
Travis, did you guys think about doing a
notice
CT esophagram or
exactly. Is that something that one could reasonably do or suggest is a contrast esophagram, as someone just mentioned?
Yeah, I'll have to look and see if they scoped him or not. Like, this is the one place that's the question right there.
Yeah.
Absolutely.
Yeah. Yeah, I think, like I said, the surgeons were not really inclined to do much of anything, even if they found something, I think, because he's stable. But yeah.
I've seen a few.
It's a very good question.
Yeah, I've seen a few aortoenteric fistula and that can look similar. If it was an esophageal leak, they could put a stent in, although there's not a lot of room in that mediastinum already. Yeah, I don't know. There was a good article in AJR, I think about a year ago, looking at the accuracy of CT esophagram for leak. And it turns out it's pretty good. We've been trying to do it lately, and it helps if you get multiple phases. If you do it like a non-con and then a prone and supine swallow, it's very, very accurate when you do all three phases.
What do you use? Water soluble, right? You wouldn't want to leave barium sitting around.
Correct. Yeah, you use and it's exquisitely sensitive to the water soluble. So you can use Omnipaque. We use Omnipaque 350, 50 mLs diluted in about 800 mLs of water, and then we make them drink at least 300 mLs.
Got it.
Yeah, we do a lot of CT esophagams here too. I was a little skeptical at first, but you're right. That article does show that it's, reasonably, adequate. So yeah, I don't know. But in this case, it was mostly just the radiographic finding, because obviously we don't have resolution on or final answer in this case. But all right, Jeff, I'll stop there.
Okay. Brian, do you have any cases this week?
Sorry, no.
That's all right. Is there anyone else I missed? All right, well, I can show a couple. So I'm glad David showed his case, because this is my companion case. So this is a young guy, he's about 25, was treated for so-called asthma over the past month, but you can see his radiograph is abnormal. He's got enlarged pulmonary arteries, big main pulmonary segment. Right atrium looks big. On the lateral, you can see the nicely enlarged pulmonary arteries, and a little bit of filling in here in the main pulmonary segment is big as well. So he presented more acutely with respiratory distress and hypotension, and you'll see why in a second. So here is his CT angio that was done somewhere else, and you can see he's got all this thrombus in his central pulmonary arteries. But I want to draw attention to his left atrium here. You can see how tiny it is and how underfilled his left ventricle is. He's got a big right atrium, big right V, hypertrophy, so this has been going on for some time. I don't see a PFO or any sort of real blow off there, but he has very poor perfusion to his lower lobes, but lots of clot along the walls, and you see it really thick here. So it looks like CTEPH. If we go to the lung windows, you can see some nice mosaic attenuation or perfusion, whatever term you like, with big vessels in the ground glass and tiny little vessels in the blacker lung. But what I thought was also kind of cool, besides his central obstruction, is he's got these funny vessels in the right lung apex here. You see these kind of spindly vessels, and they're kind of big. And if we follow them back, this one in particular, you'll see it actually seems to hook up to the left subclavian artery. So I think this is a systemic to pulmonary shunt that's probably been recruited for whatever reason. And he probably has another one up here. At least he has some transpleural collaterals. And if we follow some of these vessels, you can see they're quite tortuous, and some of them do extend towards the pleural surface a little bit. So his pulmonary arterial pressures are about 100 millimeters of mercury, very, very high. And you can imagine this is not a good situation to be in with this underfilling of the left ventricle by compression and just very little return here. So the question, of course, is this CTEPH? Is this in situ thrombus? Is it both? Well, I think I would argue this is CTEPH. He does have he had one little acute right here. He had a little acute PE. We can see it's kind of centered, and it's not the usual with that polo mint sign or whatever there. So I think that's an acute clot. And the fact that he's got these long strandy things going out, to me, although Seth was saying that maybe we can't tell the difference, but I think this is actual CTEPH, and it's been there for some time. He's got all this remodeling. He doesn't have an ASD or any other cause for PH, and it's really severe. So I don't know what kind of treatment options are. This is going to be, I think, would be a tough endarterectomy. And of course, we usually send our outpatients to Seth Center, so it's gonna be a little hard with this guy. But I don't know if anyone has any comments on this one.
Why would it be? Why do you think it would be hard? Because he's in such bad heart failure, or?
Yeah, I don't know. Our surgeons don't really do these. They didn't feel that was going to be a good option for him. They didn't think they'd be able to get enough of it out. But I'm definitely no expert.
Oh, they would drool over this here, because the only thing we get nowadays are like these, distal segmental and subsegmental disease.
Yeah.
They like doing these big central ones. I agree. I think there's definitely CTEPH here, but again, I don't know if in some patients the pressures get so high that you just start developing in situ thrombus superimposed on it. Supposedly
Right.
it's very
You
common.
kind of wonder if this is an in situ thrombus here.
Yeah.
And this is the CTEPH here.
Yeah, and there's definitely, and we have cases that are clearly mixed all the time. I just had a case of scleroderma this morning that was clearly mixed, had layering in situ thrombus, and then distally everywhere else she had CTEPH with webs and stuff. So, but yeah.
And he's very young, so that's really, really odd too, whether he's got some predisposition by
25-year-olds.
genetic or something
You
else.
wonder. Oh, go ahead, Howard. I'm sorry.
No, sorry, you must have. One would think he has a predisposition to this.
Exactly.
He's too young.
Exactly, but
Wow.
It's probably factor 5.
Something.
Factor 5 Leiden.
yeah, I guess that's pretty common relative to other ones. So
Do you
this
think
is
it could be a sarcoma?
You know, I was asked about that. I don't like it, and the reason why I don't like it for sarcomas, first of all, if you just had this, maybe, but it would not explain all of this circumferential thickening, and to have no mets in the lung with this extensive disease. And plus, this has clearly been here for some time. I mean, look at the IRV hypertrophy and all the remodeling and all these and all the shunting here and this systemic pulmonary shunt. That just to me would not go with a sarcoma because they're pretty aggressive, and I just don't think you'd have enough time to develop all that.
And the distal vessels don't contract like that in sarcoma.
Right.
See how your distal vessels are contracting? As it grows in, it'll expand the vessels out.
Right.
So yeah, I don't.
Yeah.
And
that's
have it
always a good
bilaterally
question because it's often a misdiagnosed or diagnosed late. So this is an interesting case. I think I showed a couple to you. This was originally noted on an abdominal CT that was done for some belly pain or something like that. And one of our residents noticed this, and that's how that we got to the chest. But you see there's a clot here in the inferior vena cava, and there is a filter just below the renal veins in place. So we have a clot going through there. And then there's also a thrombus in the superior mesenteric artery right at that bifurcation there. And then they notice, and I don't know if that's an old infarct or something in the spleen, but if we come up to the top of this study, we start picking up some funny looking stuff in the aorta as well. Sort of at the very end, you see there's PE, which was recognized as well, but this sort of eccentric clot, and then this weird looking stuff. There's a plaque here, but this, to me, clearly looks like some thrombus, but the question was there an acute aortic process that was leading to some of this? You see there's a big clot here in the left pulmonary artery. So we did a chest CT, and this is the non-con. It's kind of cool. You can see there's that clot on the non-con there, but no intramural hematoma. But on the angio portion of the chest, we can see the whole aorta here. So look at this. We've got this really funny adherent clot, and I'll make a sagittal, and there's probably some smoke around it. And then this really adherent clot along the wall, just kind of floating in the breeze. There's our pulmonary embolism there. So there's venous clot, systemic venous clot, pulmonary arterial clot, systemic arterial clot. The question is there a PFO? That it's a paradoxical embolus? It does not appear to be. And this almost looks like in situ thrombus rather than embolic thrombus because there's multiple ones, unless it fragmented at some point. But I guess that's a possibility. But
did they get an echo?
What?
Did they get an echo?
I believe so, and I don't think they found a shunt, if I remember.
Okay. Yeah, because I mean, us not seeing it. I mean, we're not great.
Oh, I know. Yeah, I know. We don't find them unless we get lucky usually.
Yeah.
So some kind of in situ clot, but it's just kind of a crazy looking thrombus. And I know I think one of you showed a really ratty looking aorta that ended up being a sarcoma, but I think this doesn't fit. This is just nice adherent clot and probably some smoke artifact around it from some kind of turbulent flow. But,
yeah, I would have really bet there was a PFO, but if there's not, that's great. I don't understand why there'd be both unless they have some sort of clotting issue.
Yeah, I think that's it because it's on. Yeah, that's my guess. I'll double check, but I didn't see anything that mentioned it.
It's just weird.
Yeah. I have one patient I may have shown a couple of years ago with concurrent pulmonary emboli and mobile aortic thrombi.
You know, I have like 3 cases like that, but they all have they all have PFOs. I haven't seen one without. That's pretty interesting.
Yeah, so a lot of weird vascular cases today, a lot of weird clot things, but all right. Well, if anyone else we've got a few more minutes, otherwise we'll just end today.
Let's see, I have.
It was interesting you showed that systemic to pulmonary artery collateral that you could see off the subclavian.
Yeah.
Because they're there all the time on angio. And so like something like 40% have coronary to pulmonary artery connections on angio. but we just never see them. So it's really cool that you actually could see it in that case.
Yeah, and those were even lousy 3 millimeter thick slices. The tip-off was the funny vessels. As you got up peripherally, they got really big again, like you see with systemic arterial supply elsewhere.
Yeah.
Yeah, it's
I'll show a fast case that, Jeff.
sure.
This actually, in part, speaks to the notion of what Travis mentioned earlier, which is satisfaction of search. Let me see if I actually have the right case. Okay, so this image was obtained to evaluate a PIC, and a resident correctly described the PIC, and that was it. But there is another abnormality. Let me bring a previous for comparison. And that's a long time ago. So let me put this up again, make it a bit bigger. But this is satisfaction of search potentially. Because I noticed on a previous, I could tell from previous exams that the patient had had quite extensive imaging of the lumbar spine. And I noticed something, and then we began to look some more. So here's the finding. There is an abnormal mediastinal lung interface on the left side of the thoracic spine, which is quite large and quite extensive. And a new finding from the previous radiograph is obliteration of that disc space. So it turned out that she had been treated, or was being treated, for discitis in the lumbar spine, and there was a question of whether there was drug abuse or other predispositions to infections. But the point being that that is a very real thing. And here you can see some of the MR, the abnormality consistent with a discitis at that level and paravertebral soft tissue opacity. So just kind of a satisfaction of search thing, as well as a fairly lot of pathology here. So another focus of infectious discitis with paraspinal abscess, or at least abnormal tissue right there. Okay.
All right. Well, thanks everyone. I'll talk to you later. Have a great rest of your week.
Thanks,
You too.
everyone.